Ischemic heart disease or coronary artery disease is the most common heart disease and the most important cause of death. Ischemic heart disease affecting approximately 126 million individuals, around 1.72% of the world's population. On an annual basis, 5.4 million people are diagnosed with coronary artery disease in the United States, which is responsible for over 500,000 deaths annually.
Ischemia of the heart is a result of imbalance between the perfusion and demand of the heart for oxygenated blood.
Atherosclerotic narrowing is the most common cause of ischemic heart disease in almost 90% of the patients, which is defined as a progressive inflammatory disorder of the arterial wall characterized by focal lipid-rich deposits, plaque or atheroma.
Atheroma is a well-defined yellow bulge on the inner surface of the artery, caused by sub-minimum aggregations of fat, smooth muscle cells, fibroblasts, and intercellular matrix overlays necrotic core. Necrotic center of fibrous plaque consists of cellular debris, CH crystals, and foam cells. Foam cells are formed because oxidized low-density lipoprotein is ingested by the scavenger receptors present on the macrophages and smooth muscle cells both intracellularly as well as extracellularly. Disrupted inflammatory plaques may extrude underlying necrotic material, which extends to the endothelial surface, serving as a nidus for thrombus formation, and this is the prototypical and most common mechanism of acute coronary syndrome.
There are a number of explanatory hypotheses about the pathogenesis of atherosclerosis, and this is best explained by the injury response hypothesis.
Chronic endothelial cell injury results in increased permeability, leukocyte adhesion, and thrombotic potential. This is associated with accumulation of lipoproteins, mainly low-density lipoprotein. Macrophages infiltrate the intima, and platelets adhere to damaged endothelium. Platelets induce inflammatory responses in both leukocytes and endothelial cells, while inflammatory cells release cytokines and growth factors, as platelet-derived growth factor. The activated platelets release factors causing migration of smooth muscle cells from the media to intima, and their proliferation along with release of proteoglycans and collagen, and this results in enhanced accumulation of lipids. There are a number of risk factors that contribute to the formation of atherosclerotic plaques. Non-modifiable risk factors include age, gender, and family history. The incidence of coronary artery disease typically started in the fourth decade and increased with age. Men over 45 years old and women over 55 years old are more likely to develop coronary artery disease. Male were more likely to be affected than female, but postmenopausal female have the same risk as males, due to a lack of protective estrogen. In the UK, 1 in 3 men and 1 in 4 women die from coronary artery disease. A family history of premature coronary artery disease is established when there is definite myocardial infarction or sudden death before 55 years of age in a first-degree male relative, or before 65 years of age in a first-degree female relative. Modifiable risk factors include hypertension, hyperlipidemia, diabetes mellitus, and chronic kidney disease. Hypertension is the most common risk factor. Uncontrolled high blood pressure can make arteries hard and stiff, which in turn contributes to narrowing of blood vessels and slowing blood flow. 2. Hyperlipidemia. Too much bad cholesterol or low-density lipoprotein increase the risk of atherosclerosis. Also, not enough good cholesterol or high-density lipoprotein increase the risk. 3. Diabetes mellitus is the worst risk factor. Type 2 diabetes and coronary artery disease share some risk factors, such as obesity and high blood pressure. 4. Chronic kidney disease. Long-term kidney disease also increases the risk of coronary artery disease. Lifestyle risk factors include 1. Smoking. There is a strong dose-linked relationship between cigarette smoking and coronary artery disease. People who smoke have a significantly increased risk of heart disease, and breathing in secondhand smoke also increases the risk. 2. Alcohol abuse. Alcohol is associated with reduced rates of coronary disease, but heavy alcohol use can lead to heart muscle damage. And it is associated with hypertension and cerebrovascular disease, which it can also worsen other risk factors of coronary artery disease. 3. Sedentary lifestyle and obesity are independent risk factors. Obesity can lead to type 2 diabetes and high blood pressure, and a lack of exercise or sedentary lifestyle is linked to coronary artery disease and some of its risk factors. 4. Unhealthy diet. Eating foods with a lot of saturated fat, trans fat, salt and sugar can increase the risk of coronary artery disease. Also, diets deficient in fresh fruit, vegetables and polyunsaturated fatty acids are associated with an increased risk of vascular disease. 5. Stress and type of personality. Emotional stress may damage the arteries and worsen other risk factors for coronary artery disease. 6. Amount of sleep. Too little and too much sleep have both been linked to an increased risk of heart disease.
Coronary artery disease can have the following clinical presentations. 1. Asymptomatic. 2. Stable angina pectoris. 3. Acute coronary syndrome, which in turn is divided into unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. 4. Sudden cardiac death. Usually atheroma remain clinically silent until atheroma becomes large enough to impair arterial perfusion. As the atheroma grows, less blood can flow through the arteries. As a result, the heart muscle can't get the blood or oxygen it needs. This can lead to chest pain, stable angina.